Clinical Judgment, Week 11. This week we have a client who is a 67-year-old female admitted with abdominal pain and a mass. She had exploratory laparotomy yesterday. And these are the assessment findings. The client is an insulin-dependent diabetic. She has a blood pressure of 116/80. She's receiving D5W at 50 mLs per hour. She has an NG to intermittent suction with green-brown mucus. She has a Foley with clear, slightly dark amber urine. She states, "I'm very tired and nauseated." She has a temperature of 98.4 oral. Her respiratory rate is 20 breaths per minute. Her blood sugar is 210. Her heart rate is 86 beats per minute. She has active bowel sounds times 4 quadrants. Look at these findings. What findings are going to be relevant or most important to this client? As you progress through your nursing career, you should be able to, without sitting down listening to every cue, be able to pick up insulin diabetic, that's pertinent. Blood pressure, 116/80, that's normal, we're good. D5, and so on and so forth. So as you progress in your nursing career, this is going to become more of an automatic thing. So, insulin-dependent diabetes mellitus. We don't really have the cause for this, but we do know that implications would be that it increases the client's risk for postoperative complications, such as healing, slows healing down, increased risk for infection, etc. The fact that she is receiving D5W at 50 mLs per hour, we know that this is an appropriate IV postoperatively, but maybe the fluid might be too slow and the wrong fluid for this client. She's diabetic and she's receiving dextrose. That's only going to increase her blood sugar. She has the NG to intermittent suction with green-brown mucus. We know that this is pretty much normal effluent, in other words, drainage, but we have to make sure that we have proper positioning. We'll look at why that could be pertinent here in just a couple of minutes. She has the Foley with clear, slightly dark amber urine. Well, it's slightly dark. That means she could have a fluid volume deficit, or this could be caused by an acute kidney injury. Complaints of fatigue and nausea. Well, she just had gastric surgery. Of course, she's going to be fatigued. She's still going to be feeling the effects of not only the anesthesia, but the procedure itself. That was a trauma on her body. She could have fatigue because of that elevated blood sugar. She could have nausea because of a paralytic ileus, where her bowel does not have the peristaltic movement. It could also be because of medications. We do know that pain medications could definitely cause some nausea. It could also cause her to feel fatigued because it has a sedative effect. And we know that the NG tube might cause some gagging issues in and of itself, or if it's improperly placed and it's not suctioning appropriately, then the secretions could be building up in the stomach, and that could cause the nausea. We also know that having a really dry mouth or halitosis, the bad breath, could cause some nausea. What about her blood sugar being elevated? Well, we know that elevated blood sugar could be caused by her diabetes. Maybe she has an inappropriate diet, but we know that she is right now NPO because she has the NG tube, but she's getting the D5W. So that could cause an elevated blood sugar. But what else can cause an elevated blood sugar? Remember, what does stress do to our bodies? Stress causes the release of corticosteroids. Steroids cause an elevation in blood sugar. And lastly, we have active bowel sounds times 4. That's a normal finding. So why did I select this? Usually it's going to mean that peristalsis has returned. But remember, she also has an NG tube. So that nasogastric tube is going down into the stomach and it's intermittently suctioning out secretions. Was the tube clamped prior to auscultation? Or was the suction turned off prior to auscultation? Because if it was not, then that could indicate that maybe we're just hearing suctioning sounds. So potential complications. Well, diabetes. We know that she is at increased risk for organ damage due to her abnormal blood sugars. It could cause hypo or hyperglycemia events. But we also know because of the surgery that she could have slowed wound healing and it could lead to infection. Her IV fluids at 50 mLs per hour. Well, in some people, this could cause fluid volume overload, but that is a pretty slow rate, so probably not. But it definitely could cause an electrolyte imbalance. That NG tube, well, if there's too much tension on the NG tube, it can actually cause skin impairment. And if we have skin impairment, it's probably going to be around the nares. It can actually cause a medical device pressure injury. If we suction out too much, it can lead to metabolic alkalosis or dehydration. The slightly dark amber urine, we're looking at dehydration. The fatigue and nausea could lead to depression or malnutrition, dehydration, or electrolyte imbalance. Elevated blood sugar could lead to organ damage. And active bowel sounds, well, there's really not a complication for that one. So non-applicable. So what do you think is going on with this client? This is what I think. I think that overall she's having a normal postoperative gastrointestinal stay. I do think she has elevated blood sugar, so she is at an increased risk for postoperative complications. So our priorities, the elevated glucose and potential postoperative complications. So we expect her blood sugars to be within normal limits for her, and we expect there to be no postoperative complications. So anything we should avoid here? Well, definitely avoid giving more sugar. So what would we do? Well, we need to monitor blood sugars and monitor her for complications. Administer some antiemetics. Most likely administer some insulin subcutaneously. We need to ambulate her. This is going to be a typical postoperative intervention. Provide oral care, do our breathing exercises, moisten her mouth routinely. She can't eat or drink, so we need to keep her mouth moist somehow. Do the sterile dressing changes per orders. Do the anti-embolism stockings to help potentially prevent some DVTs. And this could also include the sequential compression devices. Minimize opioids as appropriate. In other words, she's probably going to need opioids postoperative, but we need to not just administer them randomly. We give them only when she truly needs it. And we definitely need to change her IV fluids to no dextrose. So what issues are potentially limb or life-threatening? Again, that's her blood sugar and postoperative complications. So what do we do? Well, definitely, let's get that IV fluid changed. That would be the very first thing I would do, and probably give insulin. If we do those two things, we are definitely going to help reduce the risk for postoperative complications. And then, of course, monitor her blood sugar. As far as postoperative complications, again, the insulin and changing the IV fluids. But let's ambulate her. Let's do oral care. Let's monitor for complications. Doing the turn, cough, deep breathing, anti-embolism stockings or SCDs, minimizing opioids, changing the dressing per orders, etc. Did our interventions work? Do we need to change anything? Do we need to make any adjustments? So what client do we need to see first in this issue? Is it the client who's 1 hour postoperative who's very drowsy? Is it the client who's 1 day postoperative with absent bowel sounds? Is it the client 3 days postoperative with crackles in the lungs and an O2 sat of 93%? Is it the client 2 days postoperative with a temp of 99.9 and pain 5 out of 10? Well, number one, we expect the client to still be drowsy 1 hour after surgery. They still are experiencing some of the effects of the anesthesia. Is it number two? Well, 1 day post-op with absent bowel sounds, especially if it was a gastric surgery, we know that anesthesia can slow down and or paralyze the peristaltic activity. So absent bowel sounds 1 day post-op, yeah, that's pretty normal. We just make sure we get the client out of bed and ambulate. We have a client 3 days post-op that now has crackles in the lungs and an O2 sat that is acceptable, but it's on the lower end. Well, we're looking at potential fluid volume overload there and a decreased oxygen perfusion. Or the client 2 days post-op with an elevated temp. Well, we 2 days post-op could be looking at potential infection. We do expect the pain to be elevated after movement. So this is important. It is urgent to take care of them, but is it emergent? I'm looking at number 3. We're talking respiratory ABCs. We have crackles in the lungs, fluid volume overload, and we have a low oxygen saturation. So that fluid volume overload is starting to affect our perfusion. Okay, we have a nurse who screens a preoperative client for conditions that may increase the risk for complications during the preoperative period. Which conditions are possible risk factors? This question, exactly what it says. What are operative risks? Is it being emotionally stable? Probably not. Is it being 57 years of age? Probably not. Is it obesity? Yes, we know that this is a definite risk factor. Is it being a marathon runner? I doubt it. These people are probably pretty fit and pretty healthy. Is it pulmonary disease? Yes, anesthesia will definitely mess with that. And hypertension? Yes. Correct answers 3, 5, and 6. We now have a 75-year-old client who had an exploratory laparotomy tomorrow. The wife tells the nurse that at night the client gets up and walks around his room. What priority action does the nurse take after hearing this information? Well, what is this question asking? Why is this an issue? Well, at night the client gets up and walks around the room. This is strange surroundings. He's 75. After surgery, especially, he could be suffering from delirium. Basically, this is a safety issue. So priority, if we do not do this, the client could have potential life-threatening or life-changing issues. Is it the nurse notifies the provider? The nurse develops a plan to keep the client safe. The nurse obtains an order for sleep medication. The nurse tells the client not to get out of bed at night. Well, first of all, how effective would telling the client to not get out of bed at night be? He's probably not aware that he does that. Sleep medication could only make the client more confused and could potentially be a safety risk. We need to develop that plan to keep the client safe. Number 2. Which nursing intervention is most appropriate for the client in the operative setting? So, what is this question asking? There really could be multiple options here. So let's look what our responses are. Is it the client just a minute, I got lost here. Is it that we should provide a climate of privacy, comfort, and confidentiality when caring for this client? Is it we instruct the client that after the preoperative medication has taken effect, he or she will be drowsy? Is it avoid discussing the activities taking place around the client while in the holding area? Or is it assist the members of the surgical team readying the operating suite? The correct answer is going to be number 1. Next question. What is the primary purpose of a post-anesthesia care unit? Well, what is this question asking? This question is actually asking, why do clients go to the PACU after surgery? Trying to get back to the correct screen here. I apologize. There we go. Okay, so we got this one. Let me look here. Okay, we are looking at the primary purpose of the PACU. Would we follow through on the surgeon's postoperative orders? Would we provide ongoing critical evaluation and stabilization of the client? Would we prevent a lengthened hospital stay? Would we obtain the arousal of the client following the use of conscious sedation? Well, the PACU is going to critically evaluate and stabilize the client after a surgical procedure and make sure that they're stable prior to going back to their original unit. So next question, which interventions must the operating room or OR nurses provide for client physiological integrity during the intraoperative period? Select all that apply. So what is this question asking? Well, we need to know what physiological integrity would be, and how do we monitor physiological integrity? Would it be apply padding to the OR bed to protect skin integrity? Well, physiological is going to be our health status, our body status. So yeah, we want to prevent potential skin impairment. So number one would be very correct. Would we communicate the client's fears about anesthesia to the nurse anesthetist? That is going to be psychosocial, not physiological. Would we monitor the client's airway, vital signs, electrocardiogram, and oxygen saturation during and after sedation? Well, we're talking about the OR nurses. Do the OR nurses do that? That's the anesthesiologist's job. Do we assess and document skin condition before transferring the client to the post-anesthesia care unit? Well, this is definitely a nurse's job. We need to assess the client before we remove them from our care. Do we ensure that the client's wishes about advanced directives are respected? Is that physiological? No, that's going to once again be more psychosocial. Would we reposition the client every 2 hours, especially for very long surgeries? First of all, is this practical? We know that repositioning is a very important thing to help prevent skin impairment. But if we are to reposition the patient, we're going to be interfering with the surgical procedure and the sterile field. So even though this is a good response for physiological integrity, we know that the OR nurse is not going to do that. Correct answers are 1 and 4. Last question. The client is recovering in a post-anesthesia care unit environment that advances the client quickly from a phase 1 care level to a phase 3 care level, preparing for discharge to home. What type of surgery is this client most likely having? So what is this question asking? Not only what type of surgery, but if the client quickly meets PACU requirements, what type of surgery was likely performed? Was it elective surgery, emergency surgery, same-day surgery, urgent surgery? Most likely, same-day surgery.